All right, today we're diving straight into the heart of nursing, the implementation phase. This is where all the planning and thinking turns into doing. It's where you take that care plan and make it happen for your patient. And you know it, this is a huge high-stakes area on exams like the NCLEX. So let's get into the action.
So here's our game plan. We'll start with the standardized tools every nurse uses to keep things safe. Then we'll talk about the critical safety checks you got to do before any intervention. After that, we'll get into the hands-on care and teaching, then tackle the legal landmine of delegation, and we'll wrap it all up with a quick high-yield NCLEX recap.
Okay, first up, the nurse's action plan. Now, the big idea here is that we don't just walk in and wing it. We're using a toolkit of standardized, evidence-based guides to make sure every single patient gets safe, consistent, high-quality care. It doesn't matter who's on shift, the standard of care stays the same. So, at its core, implementation is the action step. It's where the rubber meets the road. But, and this is key, it's not a one-way street. As you're doing, you're also constantly reassessing. You're watching how the patient is responding. If something changes, boom, you could be right back in the assessment phase. It's this constant, dynamic loop.
So what's in this toolkit? Well, we've got three main things. First are the clinical practice guidelines and protocols. Think of these as our roadmaps, making sure everything we do is backed by research. Then you have care bundles, which are kind of like a package deal of interventions that work best when they're all done together. And finally, the one we're going to focus on, standing orders. These are your absolute safety net in an emergency. And this is why standing orders are so powerful. Imagine your patient's condition is changing for the worse, and it's happening fast. You don't have time to page a doctor and wait for them to call back. A standing order is a pre-approved set of instructions that gives you the legal authority to act right now to stabilize your patient. It's a game changer.
Okay, let's test this out. Your ICU patient's monitor starts flashing a really dangerous rhythm. You know there's a standing order for the situation, so what's its main purpose? It's all about empowering you to act. It gives you the legal cover you need to intervene immediately, give the right medication, and then call the provider. That speed is literally what saves lives.
Now let's move on. Before we can do anything for our patient, we have to prepare. The best way to think about this is like a pilot's pre-flight check, right? You'd never want a pilot to just skip their safety checklist, and we absolutely do not skip ours in nursing. And what is the single most important step on that checklist? It's this: reassess the patient. Always, every single time. You can't just walk into a room and blindly follow a plan that was made an hour ago or even 5 minutes ago. A patient's condition can change in a heartbeat. So here's how that loop works. You've got your plan, you go to the patient's bedside, and you stop. You reassess. Has anything changed? If the answer is yes, you don't just push forward. You stop, you gather new data, you figure out what's going on, and you adjust the plan. This simple safety loop prevents so many mistakes.
Part of that pre-flight check is also getting all your ducks in a row. Do you have enough time? The right equipment? Here's a pro tip. Always bring extra sterile supplies into the room. It'll save you from having to break that sterile field because you forgot something. Do you need another set of hands? Is the room private and safe? And finally, is your patient actually ready for this, both physically and mentally?
Let's apply this. You've got an order for digoxin, but your pre-flight check, that reassessment, shows the patient's apical pulse is 52. You know the protocol says to hold for a pulse less than 60. So what's your next move? You hold the med, you document what you found, and you notify the provider. You just used reassessment to stop a potentially deadly medication error. That's how it works.
Okay, so now that we're all prepped and it's safe to go, let's talk about the hands-on part of the job. But here's something to always remember. The goal of our hands-on care isn't to make the patient dependent on us. It's actually the opposite. It's to empower them to be as independent as possible. And this is where we see two types of activities we help with. On one side, you have ADLs, activities of daily living. Think basic survival stuff: eating, bathing, walking around. On the other side, you've got IADLs, or instrumental activities of daily living. These are the more complex things someone needs to do to live on their own, like managing their meds, shopping for food, or keeping their house clean.
A huge part of promoting independence is teaching, and there is one golden rule, one non-negotiable safety standard here. You have to use the teach-back method. You never, ever just ask, "Do you understand?" Because the answer will almost always be yes, even if it's not true. Instead, you say something like, "Okay, to make sure I explain that well, can you show me how you're going to use this inhaler?" It's the only way to know for sure that they get it.
All right, our last big topic before the recap: delegation. I call this the legal landmine because if you get this wrong, the consequences are serious. for your patient and for your nursing license. Let's be real, the pressure to be efficient is intense, and that's when bad delegation happens. It's a huge pitfall, but a skill you have to master. And the NCLEX loves to test one simple question: who is accountable? Look, as a registered nurse, you're leading a team. You physically cannot do everything for every single patient by yourself. It's impossible. So you have to delegate. But the million-dollar question for your license and your patient safety is this: what can you actually, safely, and legally hand off to somebody else? This right here, this is the unbreakable golden rule of delegation. You have to burn this into your brain. You can delegate a task, but you can never, ever delegate the nursing process. That means no delegating assessment, diagnosis, planning, or evaluation. So for example, you can delegate the task of taking a blood pressure, but you can't delegate the clinical judgment it takes to assess a patient who's showing signs of a stroke. So when can you delegate? It has to pass these 3 critical filters. First, and this is the absolute deal breaker, the patient must be stable with a predictable outcome. You never delegate tasks on an unstable patient, period. Second, the task itself has to be routine and repetitive, like helping with a bath. And third, you have to be confident that the person you're delegating to is trained and competent to do that specific thing.
Now, this is a really important legal distinction. The assistive personnel, or AP, is responsible for doing the task correctly, but you, the RN, remain accountable for the patient's overall outcome. So if the AP does the task perfectly, but you fail to see the significance of the result, you are still the one who is ultimately accountable for what happens next.
Okay, let's run a final check with a classic NCLEX-style question. Which of these can you delegate? Let's see. A, assess skin on a new admission. Nope, that's assessment. B, feed a new stroke patient with dysphagia. No way, that patient is unstable. D, teach a patient how to use a walker. Absolutely not, that's teaching. The only correct answer is C, getting vitals on a stable patient after they get back from an x-ray. It's a routine task on a stable patient. That is safe delegation.
Whew. Okay, we've covered a ton of ground. Let's lock in the most important, high-yield takeaways for your exams and your practice with a quick recap of the absolute must-know points.
Here's your cheat sheet. Standing orders, they let you act fast and legally in an emergency. Reassessment, that's your non-negotiable stop sign before every single thing you do. ADLs versus IADLs, know that ADLs are for basic survival, IADLs are for complex living. Delegation, simple. Delegate routine tasks on stable patients only. Never delegate assessment, judgment, or teaching. And finally, you prevent most bad outcomes by doing that pre-flight check before you even enter the room. So, we've mastered the doing phase. We know how to prepare, how to act safely, and how to delegate legally. But this brings us to the final, really important question. How do you know if any of it actually worked? How do you evaluate whether your actions led to the successful outcomes you were hoping for? Well, that's what we'll tackle in our next explainer.